Welcome to the Tudor Dixon Podcast. We have a podcast for you today that is very timely because right now I think the entire world is looking at the Health and Human Services Secretary and saying what exactly is going on. And what we're seeing right now seems almost like a battle of the pharma giants against the MAHA movement. And there's like this black and white line. It's like you're either on the black and one side or the other of this issue. You cannot cross that line. And that's what we're seeing in these hearings right now is that people who haven't been in the medical profession feel like there's yes and no to everything, that there's no gray area. And I think the MAHA movement has come in and said there is a big gray area that we haven't been able to talk about for a long time. And suddenly we're able to say, you know what, maybe this isn't working for everybody and maybe this doesn't work for everybody. And there's a massive backlash against the idea that some pharmaceuticals might not work for everybody. I mean, one of them is the COVID vaccine, where you have the Health and Human Services Secretary saying not every kid has to have it. In fact, in Germany, it shows that kids that didn't have any other underlying symptoms didn't die from COVID. They don't really get sick from it. So I am excited today because we have Dr. Adam Urato with me. You've heard me talk about what he has worked on. I've written an op-ed on some of his work. He is a fetal and maternal medicine specialist serving as the chief of the maternal fetal medicine at Metro West Medical Center in Massachusetts, and he specializes in high-risk pregnancies. Thank you so much for being on today.
It's a real pleasure to join you, and I really appreciate your bringing attention to this issue.
To me, it's something that I think, like I said, everybody feels like they have to be on one side or the other. And there's a few doctors right now who are coming out and saying, you know what? There are times when this medication might be necessary, but we should be very cautious about who we use medications with. And I think that kind of is spanning a lot of different types of medications right now. I think one of the most powerful things I've heard you say is chemicals have consequences.
Yeah, I think your point's a very good one, which is that there's not a one-size-fits-all answer to all of this. And this is particularly true in the area that I talk about, which is depression and antidepressants in pregnancy. Before I start, I just want to say that this topic that I try to raise attention to, this issue about chemicals, which I'm going to address that issue, the idea is to try to inform the public. And so that's really the key. That's really my goal. It's been cast, particularly after the FDA conference, it's been cast as, is it designed to be pill shaming pregnant women or disregarding their depression or making light of it, pill shaming, guilt tripping, things like that? From my standpoint, it's none of that. What it's all about is just getting proper information out to patients and the public. Depression can be awful. Human suffering is awful. And these patients deserve compassionate care. But I always make the point that part of compassionate care is proper information, accurately informing patients and the public. And part of that accurate information, informing the patients and the public, is getting people to understand that medications, by and large, are chemicals, and they're synthesized in chemical manufacturing facilities, and they have consequences in the body. That's what chemicals do. They have chemical effects. I tell people when I lecture on this, they're not like growing on trees. They're being made in chemical plants. And then when they go into the body, for example, in pregnancy, they go into the mom, they cross over the placenta, they go into the baby, and what they do is they have chemical effects. Now, it doesn't mean we can't use medications, but it means we have to always be aware of the chemical effects and the consequences. That's where I started using that phrase, that chemicals have consequences.
And so you recently had a panel on this, and I think that one of the compassionate care issue is what is really the controversy here, because people do get concerned if you say, well, we've looked at this and potentially there are risks that we didn't know, and we shouldn't be so quick to give out this medication. Not to say that it's not right for some people, but maybe we're too quick to give it to all people. And people who have been on the medication or doctors who have given it out, you can see that there is a hesitancy or even kind of a strong reaction to say, please don't say that I was wrong in what I did. And I can feel that as a mom who's been pregnant. Now you hear, there's this new study coming out that says pregnant mothers shouldn't take Tylenol. And when I was pregnant, it was pregnant mothers shouldn't take Advil, you should take Tylenol. And now there's all this news articles coming out. And I go, in my head, I go, gosh, how many times did I take Tylenol? Did I take Tylenol? You know, so it's a very personal discussion.
I tell the moms I take care of, I'm a clinician, I take care of pregnant women every day. I tell them not to blame themselves. That's what they always do. Whenever something comes out, a news story, or whenever something occurs in the pregnancy, they first blame themselves. That, you know, we're all on the same team. We're not trying to blame anybody here, except we're just trying to get the proper information and then get that out to pregnant women and the public. What I think is happening, though, is that we are all on the same team in a sense, but the pharmaceuticals industry's main goal is actually not to be getting out proper information to patients and the public. The pharmaceutical industry's main goal, Pharma, wants to increase sales and profits and return to shareholders. So what they do in these various subjects, whatever the medication is or the pharmaceutical is that they try to kind of roll out the product, and they typically roll it out with basically a sales pitch. And that sales pitch almost always follows the same routine. And what that is they create fear about the condition, whether that's an infection or whether that's depression. They create fear about that, and then they sell what they have as the cure, and they roll their drug out as being almost entirely safe and very effective. And then what we learn over time as people are using it is that it wasn't as safe, it's not as safe as originally billed, and it's not as effective. What people have to remember is that the sales pitch is designed to increase sales, but it's not the truth. And what we need to do as a human community is to try to get at the truth. And the way we do that is with studies, with research, etc. In this particular case with the SSRI antidepressants, the sales pitch is that depression is harmful in pregnancy, leads to poor outcomes. So the moms should take these SSRI chemicals, these antidepressants, thus reducing their depression and leading to better pregnancy outcomes. That's the sales pitch, but that's actually not supported by the scientific evidence. What we see with the actual scientific evidence are poor outcomes in the moms who are taking SSRIs. That's simply what the science shows. We see, and I'll march through quickly, is that we see increased rates, for example, of miscarriage, of birth defects, increased rates of preterm birth and low birth weight. We see increased rates of a condition called preeclampsia, which can be quite dangerous. It's a significant cause of morbidity and mortality. And we see increased rates of postpartum hemorrhage for sure. That's very clear that these SSRIs lead to increased rates of hemorrhage. After the babies are born, we see increased newborn problems, including NICU admissions and other issues. And then the big question is long-term what the effects are here. And this is being studied now, but we are finding that children who were exposed in utero are showing in studies, some studies, increased rates of depression, increased rates of speech and language disorders, increased rates of neurobehavioral issues, ADHD, autism. So this is the truth of what we're actually seeing in the science, as opposed to this sales pitch, as I was saying, which a lot of these drugs and pharmaceuticals get rolled out with. But what the public needs to understand is that the sales pitch, what the pitch that's designed to sell the pharmaceutical products, the drugs, and otherwise, is not going to actually be the truth, the reality for when they're used in the human populations.
So let me give a little background from my experience with this, because I had a friend who was involved with getting drugs approved by the FDA, and then they would fund the lab, and then, you know, that is just a cash cow. Once you get it approved, then you bring in hundreds of millions or billions of dollars. And it was kind of like, the way it worked was you go in front of, almost like, you know, the FDA panel is like the Wizard of Oz, right? You go in front of them and you're like, can I get through this? Can I get them to say, you know what, we bless you, you can go on and sell this drug? And there's a lot that goes through, and sometimes you get kicked back and you have to get some more information. And there's a lot that goes through this, but it seems as though, from my experience with these folks, and you can correct me if I'm wrong, once you get that wave of approval, no one goes back afterward and says, actually, or rarely do they go back afterwards, or it takes years for them to go back afterwards and say, hey, this isn't doing what it's supposed to be doing. You were one of the early voices that came out against a drug called, I think it's McKenna, and said, I don't think this is having the effects that it's supposed to have. And that was not welcomed feedback.
Yeah, and McKenna was a drug used for preterm birth or to prevent recurrent preterm birth, and we started using that around 2003 in obstetrics to prevent a woman who'd had a preterm birth from having another preterm birth. But the study that the approval was based on at the FDA, and I like the way you explained that going before the Wizard of Oz, the study that was based on was very shaky. There were a lot of limitations of that study. So from the get-go, I thought that I had real concerns about the drug, but then it got adopted and readily and rapidly used. And again, it was rolled out with the sort of pharmaceutical rollout of it's safe, it's effective, it prevents a recurrent preterm birth. But as we studied it more and more over time, it was shown to actually not be effective. And I was an active voice against that, which is another issue here, which is a lot of people have just heard me talking about antidepressants, but my interest here is in actually just informing pregnant women and the public about the medications they're taking. And I did play a role with McKenna. So we petitioned the FDA about this. When the second trial came out, which was the confirmatory trial, which took years to do, but when it came out, it was shown that it actually was not effective, which is what many of us had been saying all along. And so it was pulled off the market. It was pulled off in 2023. But it's a great example of this sort of classic pharma playbook where they get the approval and then they start the rollout, and the rollout is to scare the population about the condition, which in this case was preterm birth, and then to oversell essentially that they're safe, that they're effective, not mention risks and highlight benefits. But then over time, it's often shown, as I was saying earlier, to be not to have more risks than we were being told about, and to be less effective than we were told about. This is the typical trajectory of a lot of the medications that patients use.
So I want to be clear. I don't talk about these things because I think everybody should question every medication from now on. I mean, certainly, I've had enough times where you get an infection and you take an antibiotic, and if we didn't have those, we would not be alive today. Many of us would not survive a simple infection. There are medications that are great, that do great things and save lives. And I think that's why there's been this societal push that anytime there's a new medication, you accept it, because you don't want people to start to become skeptical of all medications. And so that there is a delicate balance there. We actually had an author on who was exposing some of the products that had come out of Johnson & Johnson. And there was one in particular that was a vaginal mesh that came out, and it was on the market for 20 years. And people had been saying, this is causing these women severe problems. And I mean, the problems were devastating in a third of women. So it's like, well, it's not all of women, but a third of women who have this is a lot of women, and it took 20 years, more than 20 years, to get that off the market, because I do think that even doctors seem afraid to push back when they see something that's not right.
Yeah, I think that there's a certain self-censorship that goes on where people are afraid to rock the boat. I think that a conventional wisdom develops, or a scientific consensus, and then physicians become afraid to be seen as running against that consensus for a variety of reasons. And so then they self-censor, and we end up with censorship, which is not good, because oftentimes the dissenting voices are correct on issues. So I always make that point, whether it's with McKenna.
Isn't that what science is really about, is to have discussion?
Absolutely. That's exactly right, Tudor. Dissent is essentially the heart of science. And so really we want to encourage dissenting voices. Unfortunately, our society has taken a turn for the worse on this. maybe before COVID or since COVID, with this idea of trying to censor and basically not allow dissenting voices, saying that they're dangerous, et cetera, they're harmful to patients, harmful to public health. But that's a real turn in the wrong direction, because as you were just saying, it's the heart and soul of the scientific method. Dissent is like the essence of science, and we need to hear dissenting voices, and that's often where the new ideas and where the correct ideas are coming from.
I saw an article that came out in response to your FDA panel. So there was recently an FDA panel on SSRIs in pregnant women and the effects, and you had multiple different voices up there speaking about this. And I saw a recent editorial on this, and it was a woman who is, I believe, pregnant now and has 2 little kids, and talked about the importance of her antidepressants. And it was, she's very upset about the fact that there were some questions as to whether or not this was safe for the baby. And I get that. I read it and I was like, man, I feel her. I feel exactly what she's saying. But I also understand what you're saying. And that is that you are starting to see changes. And I think the most significant issue that has sat in my chest and sat on my heart ever since I saw what you guys were talking about was that you can actually tell by looking at an ultrasound if the baby's mother is on an SSRI.
Yeah, I to get back to her, I did read that article, and I do applaud women who come forward and tell their story, and I think that they should be heard, and I applaud her for doing that. I think that some people mistake, what I'm saying. I try to explain to people that there's 2 separate issues. One issue, the issue that I'm focused on, is, do the SSRI antidepressants chemically affect the pregnancy? What are the risks? Do they chemically alter fetal brain development? And should the public be informed about that? And I think the answer to both aspects of that question are yes. I think they do impact the pregnancy. I do think they do alter fetal brain development. And I do think that the public should be warned about that. The second question about whether a given patient should stay on her antidepressant or not during her pregnancy is a very individual and complex question that requires a discussion in the office. And I do this every day with patients. And so I think sometimes people mistake my answer to the first question, which is that I think these chemicals are impacting the pregnancy and the developing brain, and that the patients and the public should be warned. They mistake that as thinking I'm talking about them and their pregnancy and a specific patient. That's not the case. That requires individualized counseling. So I think it's important to keep those issues separate. As far as the chemical impact that you're talking about, yes, the serotonin plays a crucial role in fetal development, particularly fetal brain development. And the SSRIs disrupt the serotonin system. So it just stands to reason that they would impact development of the brain. So when we're giving it during pregnancy and we're looking, for example, by ultrasound, there have been a couple of studies that have done this. One was done by Mulder in 2011 and another one by Salisbury, I believe in 2023 or 2024. And they looked at fetal movements after giving or when the women were on antidepressants. And what they found is that it alters fetal movement. The fetuses of the SSRI exposed moms are moving much more. They're less quiescent. They don't have the same quiescent periods that we would normally see. It's kind of like jittery, or they described as jittery or agitated movements. So these were 2 studies that were done, ultrasound studies that showed this. Now this corresponds to what we see after birth, where the newborns that have been exposed to SSRIs tend to be jittery and agitated. So this makes sense that we're seeing a direct chemical effect of the SSRI chemicals on the developing fetal brain. Interestingly enough, a study just came out, Tudor, I'll wrap up this. A study just came out looking at the length of the umbilical cord in babies exposed to SSRIs. And it found that the cords are longer. Now, this is the second study also showing this. The first study on this came out in 2016, and the second one just came out now. But they think that the length of the umbilical cord has to do with fetal motion, fetal activity. So all of this information would hang together. The moms are taking SSRI antidepressants, and the SSRIs are crossing the placenta, they're going into the baby, they're going into the baby's brain. They're having an impact of agitation or jitteriness or motor impacts, which is what we can see these medications do. And we're seeing that as reflected on fetal ultrasound with increased movements. And we're also seeing it with a result at birth of a longer umbilical cord, possibly due to the increased movements, and then also this jitteriness and agitation that we see during the newborn period, which has been called the newborn behavioral syndrome or newborn withdrawal or poor neonatal adaptation.
So I'm going to go to a place that it's kind of controversial, but one of the things that very controversial. I think that the country has been looking at the impacts of mental health and the changes in the mental health of our children for a couple of decades now. If you look back, I will tell you, there's a stunning difference to me between the kids that are in class with my children as compared to the children I went to school with when I was young. And most of my friends have noticed this too. There's just different behaviors. There are different ways that they metabolize their food. I mean, so many changes in what the kids of today look like as compared to the kids that I grew up with, behavior and everything. And I think that as a society, we have been saying, why are we experiencing these higher levels of autism, higher levels of ADHD, ADD, all of these things? And you mentioned that there have been studies in animals that show that as these babies grow up, if they are, in animals, rats, sheep, mice, as those animals grow up, they show signs of autistic type behaviors. And I know this is very sensitive because, of course, you talked about maternal blame and all of that. And I think that this is a area where it's very hard for us to have this discussion. But isn't it critical if this could be playing a role in some of the mental illness we're seeing in children, that this is made aware to doctors and to mothers?
Yeah, absolutely. I think you're raising a really good point, though, Tudor, about how much medication use is going on. And I think a lot of people nowadays just take this for granted. Everybody is on, several medications, but this is not how it's been. I mean, we currently are the most heavily medicated humans in human history. Americans, modern day Americans are, I would say, the most heavily medicated human beings that have ever lived on the planet. And that's going to have an impact when you're giving that many chemicals, that many medications to pregnant women, to moms and babies, and then to children. I'm seeing this in my office regularly. I'm talking now about SSRI antidepressants, but I'm seeing it with Adderall. I'm seeing it with ADHD medications. I'm seeing it with a variety of different pharmaceuticals. So it's throughout our entire population. And then to get to your specific question, are we seeing impacts in terms of behaviors? Yes, absolutely. The animal studies show fairly clearly that if you expose pregnant rats, mice, etc., to SSRIs, the offspring will behave differently. They'll have different like social behaviors, different play-seeking activities, things like that. They'll have different behaviors. And they also have different sexual behaviors. Several studies have looked at the male offspring who were exposed to SSRIs during development, and they behave differently sexually when they're studied. They have different copulatory behavior. They mount less. They put them in cages with females, and they behave differently than the unexposed males do. So
shouldn't this be a 5-alarm fire? I mean, I know this is, like I said, it's so controversial to say, but come on. I mean, at what point do we say we have got to immediately start looking at this? And there's this SSRI conversation going on right now, and there's this radical battle. And I've seen people go on the news and say, can you imagine people saying that folks need to get off of SSRIs? Everybody would be killing themselves left and right. And then there's another side that goes, man, if people get off of an SSRI and they start killing themselves, like, should we be worried about that? But this is big stuff.
Yeah, and I think people are now drawing attention to it. People are now focusing more on this. This is why I'm speaking out about it, because I agree with you. I think this is big stuff. I think this is very big stuff. We're talking about the development of the brain, of the baby's brain. And I made the point during the FDA meeting that never before in human history have we chemically altered developing babies' brains in this way. And we're doing that now, and we need to really raise attention to what the studies are showing. It's not just the rat and mice studies, it's the human studies as well. So we talked a little bit about the ultrasound studies. There's 12 MRI studies. I mean, it's not one or two. It's not, well, maybe they got the study wrong. It's 12 MRI studies now showing in humans that SSRI exposure during pregnancy leads to alterations of the brain. These are MRI studies showing this. There's 3 EEG studies. EEGs are done typically in patients that have seizures, looking at brain waves, but they do these EEG studies now on exposed newborns and exposed children, and they're finding that the brainwave patterns and the connectivity of the brain is different in those exposed to the SSRI antidepressants. And this just makes sense to most people looking at this because of what a crucial role serotonin plays in brain development. So if you tinker with that, if you interfere with that, you'd expect that you'd get downstream effects. And that's in fact what we are seeing. So I agree with you. I don't want to be accused of fear-mongering or talking about 5-alarm fires or diminishing the importance of depression, but I think your point is a very good one, which is we're now collecting data. We've got information from MRI studies, from studies on depression and language problems and autism. We've got this whole wealth of data that's showing these things, and we really need to get this information out to pregnant women and the public. And we really need to, as I was making that point at the FDA meeting, is to change the label and to have the FDA make a public statement on what the research is actually saying. Again, the research versus what the sales pitch is, which is that these drugs are essentially completely safe, very few or no risks, and very effective, which is just not what the scientific evidence is showing.
Well, I just don't understand why the discussion of side effects is then interpreted as not caring about depression.
Yeah, I think that some people that are doing this as a distraction method, to distract from the conversation. I don't want to blame all of them for this. I think some of them are well-meaning, but this is sort of a pharmaceutical technique, a big pharma industry technique to divert attention away from the issue at hand. So, for example, when the opioid crisis was raging with OxyContin and people were raising issues, look, this is a big problem, what's going on? They would often say, we need to talk more about the crisis of untreated pain in our country, focusing on pain rather than the specific question that was at hand, which is your drug or is OxyContin causing these harms? But the pharmaceutical industry moves away from the question about the drug to the question about the condition in order to divert your attention to make you take your eye off the ball. I actually saw this during McKenna when I would argue about it not being an effective preterm birth drug. I would get feedback that, well, preterm birth is an important issue and we can't ignore the women that have had a preterm birth and diminish preterm birth. And they would spend, half the time talking about preterm birth. That's more of a diversionary tactic. What you're seeing, you're seeing a lot of this in the subsequent media, the corporate media, and some of the editorials written by some of the perinatal psychiatrists. They spend most of it talking about depression. Not that depression's not important, but you need to answer the question, what are the risks of the drugs and what is the evidence of their effectiveness? And that's the question that needs to be answered. The public needs to laser focus on that.
And some of these situations are creating even deeper problems for people or more people with problems. That's the other issue when you have a pregnant mother taking these. The last thing I want to get to is the PSSD, which is the sexual dysfunction. And you talked about that in these animals. We've heard that there is potential that some of these children get to adolescence and they don't have interest in sex, or they can't perform sexually, or there are other sexual dysfunctions. One of your colleagues had an interview recently, and he went into kind of graphic detail about this and said, there are people who take these and sometimes they are permanently, sometimes there's permanent sexual dysfunction. Sometimes they can get off of the drug and that can be reversed, but too often they're not told ahead of time that this could happen. And he said that some people have described it as they can touch their genitals and it's like touching the back of their hand. They have no reaction whatsoever. That all of those receptors are no longer having any type of reaction to another person. In fact, men are even coming out and saying, women who I used to have this great relationship with, I was completely sexually attracted to, I don't have that at all. I'm questioning if I'm even a sexual person anymore. To me, this is such a critical part of relationships. And I cannot express enough that if you suddenly have a marriage and you have the one spouse that no longer has any interest in sex, you're destroying that relationship. If you have a child that gets to adolescence and they don't understand that relationship, what is the future?
Yeah, I think you're raising really important issues. I think we need to exercise, just as a general point, more humility about tinkering with the chemicals that make our brains and our bodies. Sarah, why do we behave sexually the way we do, or why do we develop in that fashion? Why do our brains develop that way? A lot of it probably has to do with the way the tracks are laid down in utero during development, and a lot of the way those brain tracks are formed in the brain is because of serotonin and other neurotransmitters. If you put medications in there like the SSRI antidepressants and others that alter those neurotransmitters, can you alter the development of those parts of the brain or those tracks that then show up later? The answer from the animal studies looks like yes, absolutely. It appears to do that. And that just makes common sense. And then does that have major implications and major ramifications? Absolutely. Yeah, I agree with you. I agree with you wholeheartedly. And that's why I think it's important that patients and the public get this information so they can make an informed choice, and that the information gets out not just to pregnant women, because really that's not the time to make the choice on this. It really needs to get out to women of childbearing age, because a lot of times the patients that I see have been on the medications for years, and many of them can't come off of them or would have great difficulty coming off of them. And this is another aspect to this, the issue of withdrawal and problems withdrawing from the drugs, difficulties in coming off. So I think that it needs to get out to women of childbearing age. Specifically with the PSSD question, I think that many people are looking at this as a chemical injury, which takes me full circle now to what I started off with this chemicals have consequences. If you're putting these chemicals into your brain, into your body, you can get chemical impacts. And then even when you're not taking them anymore, if there's been chemical toxicity, which chemicals often do have toxicity, it can have long-term effects. And in that case with PSSD, long-term sexual effects, which can be devastating.
I will tell you, so many people that I know that have taken medications or are on medications have said to me, if I had known these were the side effects, I wouldn't have originally agreed to take it. And even some side effects that are just really a pain. Some side effects like constant sweating. I have some friends who've taken these medications and they're like, and now it doesn't go. I got off the medication, but it doesn't go away. But that's your point, is people should be informed. There's so little information about how these medications are going to affect people. And that's what I want to bring attention to, is that there are other consequences to taking these medications. And is there another answer? It's not that we don't take the other issues seriously. It's that you have to make sure that there is enough information out there for people to know what they're putting into their bodies. I'll just end on, when your colleague was interviewed, they also gave an example of a young woman, 21 years old, was suffering from severe anxiety. And he said she went on this medication and there is an instant reaction. Well, sometimes it takes a couple of weeks, but there's a reaction of, okay, I feel calm now. I feel better. I needed this medication. But your body adjusts and then you need more. And as she took more, she ended up with the sexual dysfunction, and she started to get very upset about that. And she went to her doctor and they admitted her to a hospital and said, you have some sort of, you're having a mental break. And she was trying to tell her parents, I'm not having a mental break. There's something happening to me. I'm not the person I used to be. And the system was telling her, you're broken, not even coming back to her and saying, actually, the medication you're taking is wrong. And I think that in some cases, even the doctors don't know that that's what the medication does. And they're like, oh man, this is just a new thing. You're even worse now.
Yeah, there's a real lack of knowledge. Absolutely, Tudor. There's a real lack of knowledge about side effects. And I think I'm particularly sensitive to the points that you're making because I practice in my hometown. I was born, I practice, I work in the hospital I was born at, and I work in my community. And I never want my patients to come back to me 5 years from now, 10 years from now, 20 years from now and say, boy, you didn't really counsel us about those drugs, those medications, and what you were seeing in the research literature. So I feel an obligation to care for my community and to correctly counsel. So again, this is not about pill shaming, making anyone feel guilty, taking anyone's medications away. It's just about getting proper information out to patients and the public. The last thing I want to just comment on is what you mentioned about doing other things. Much of the discussion since the FDA meeting has been about, should it be SSRIs or untreated depression? But it's not a choice just between those things. I don't think anyone's arguing for ignoring pregnant women, not treating them, making them feel bad. There are other methods that can be considered in that, in terms of how to address depression, whether it's with exercise, psychotherapy, diet, job counseling, relationship counseling, taking other approaches. And so I think that looking at the whole or counseling patients about all of the options and then letting them make the best choice for themselves and then supporting them, which is what I end up doing every day in my community, is the best way to go. But the key there is to actually get them the information.
Yeah, absolutely. And I so appreciate what you're doing. There's so much more that we could talk about on this, and I'm sure we'll have to have you back to talk about it. But as we see the country kind of changing, and I get your point about this is a time when people are really saying you can't push back. But I think it's also because this is the first time people have said, maybe these three-letter agencies don't know everything and we should push back. So we are also seeing a lot of strong people stand up and say, actually, I had a bad experience too. And it's been amazing to me the number of patients who have said, even on social media, I never wanted to admit this before because I was so personally embarrassed. I thought I was the only one, but I've had this happen too. I've had this happen too. So I encourage people to keep talking. And Dr. Adam Urato, thank you so much for being out there and being a voice for all of us.
Well, thank you. And you're a big part of this pushing back through the podcast, through writing as you did recently, through having guests on like myself to keep getting the message out.
Thank you. Thank you so much. And thank you all for joining us on the Tudor Dixon Podcast for this episode. And others, go to the iHeartRadio app, Apple Podcasts, or wherever you get your podcasts, and join us next time. Have a blessed day.